Hello, my name is Homa Zadeh. I am coming to you today from my office at the University of Southern California in Los Angeles. I hope that wherever you're joining us from around the world for this presentation, you would find this educational and beneficial for your clinical practice. So now on to our presentation. Our topic today centers around the decision-making process for the selection of appropriate treatment protocol in cases where we have atrophic alveolar bone. And we can select short implants versus utilizing bone augmentation techniques followed by long implants. So we know that many of the sites where we're treating in our clinical practices have significant degree of atrophy, whether it's the maxilla with the proximity of the maxillary sinus or the mandible with severely atrophic posterior mandible, limiting our ability to place implant in those areas, necessitating at least some form of pre-implant site development and augmentation. Well, in the cases where we have atrophic posterior maxilla, of course we can perform a sinus augmentation and place long implants, or we can just simply utilize the existing bone and place short implants. And conversely, for the posterior mandible, where we have atrophic posterior mandible, we can either perform bone augmentation and place standard length implants and restore them, or we could place short implants and call it a day. So what would be the pros and cons of selecting short implants versus bone augmentation? I would like to discuss with you what are the considerations. So when we're discussing about short implants, there are two basic considerations that we would like to consider to determine whether they're appropriate for our patients. The first is the theoretical consideration. Can short implants withstand occlusal stresses? And that is just purely mathematical. The second is whether or not in clinical studies short implants can be demonstrated to be as effective as conventional implants. Now, in dentistry, many times we give certain types of restoration. We tell our patients, well, we're going to give you this tooth, but you really can't function, you can't really chew with it. That's really, in my view, is not acceptable. That's a compromise. I'm not interested in a compromise. I'm only able to be interested in this particular treatment option of using short implants if it's a viable alternative to placing long implants. So let's see what the evidence shows. The first consideration is the biomechanical consideration. When we're considering implant length as a function of how that would distribute load to the surrounding bone, there are mathematical calculations of using a technique called finite element analysis. Using finite element analysis in this particular study, the investigators used implants of different lengths, anywhere from 8 up to 17 millimeters. They kept the diameter constant, and they asked the questions, is increasing the length of the implant an effective means of controlling stresses to the bone? So the hypothesis is that by increasing the length of our implants, we are reducing the amount of stress to the peri-implant bone. So let's see if this theory really holds up in terms of the data. Well, the data is very interesting because counterintuitively it demonstrates that no, lengthening the implant is not an effective way to reducing the stresses. In fact, the difference between the stress on 8 and 17 millimeter implant was only 7.3%. So using long implants is not a very effective way to try to reduce peri-implant bone stresses. Let's take on the converse situation to see if implant diameter has any role in peri-implant stresses. So in this investigation, the scientists increased the diameter of the implants anywhere from 2.9 to 6.5, keeping the length constant now, and they asked the question whether or not there's any effect on relative stresses to the peri-implant bone. And what they found is that indeed there was a very sharp decline in stresses by using longer or wider implants. So what they found was that the difference between the stress on 2.9 and 6.5 millimeter implant was 60%. So this is really very significant. So what we've seen from that data, and that's been demonstrated by multiple investigators, is that length does not seem to matter in terms of bone stresses, but diameter seems to be very important. In order to understand why is diameter more important than length when it comes to biomechanical considerations, we have to look at the stress map to see where the stresses are to the implants when they're in bone. And what we can see in this particular comparison of short and long implants, what is seen is that the vast majority of the stresses are focused on the crestal portion of the implant. And regardless of the length, what seems to happen is that the crestal 5 or 6 millimeters of the implant are taking most of the stresses. The apical portions of implants are taking virtually no stresses. So this is very interesting, which explains why length is not important, but diameter is, because by increasing the diameter, we're providing more surface area right at the crest for stress distribution. Now, what I like to point out at this point is that when it comes to implant outcomes, we don't only have biomechanical considerations, because there's other considerations to take into account also. We have to take into account physiologic considerations. Well, even though it seems that from a biomechanical standpoint, using wide diameter implants is a good idea, physiologically that will not be, because by using a wide diameter implant, we are compromising the circulation to the bone and really pushing the limit in terms of occupying the volume within that bone with a titanium device that does not have its own blood circulation. So let's take on the clinical consideration. Now, in this area, we have to first decide what is the definition of a short implant. Well, as it turns out, this is not a simple task, because in various investigations, short implants have been defined with different parameters. Short implants have been defined as anything of 10 millimeter all the way down to less than 7 millimeter or equal to 7 millimeter. So depending on which source you utilize, there are different definitions of short implants. So that's something to keep in mind when we're looking at the study. In this particular systematic review, and there have been a number of systematic reviews in the recent years which really demonstrate how important short implants are because of the great interest in evaluating the literature in this area and expressing them in a systematic review format. In this particular systematic review, what was considered was the cumulative survival rate of implants that have been reported for at least 5 years. And interestingly, when one compares the cumulative survival rate of short versus long implants, we can see that they're virtually identical, very similar in the very high 90%, so 98 or 97%. What is more interesting, actually, when we consider the failures that did occur within the short implant groups, 70% of those failures that have been reported have occurred before loading. What does that tell us? That would tell me that the failure of those 70% of short implants was most likely not due to the inability to withstand occlusal stresses. So factors other than overload must be responsible for the failure of short implants. So this will reject the hypothesis that length is important for the clinical survival of short implant. Now, let's look a little further into the systematic review of the literature with short implants. What is clearly seen is that the survival rate in the maxilla is lower because there's 3 times the amount of failure of short implants in the maxilla than in the mandible when we're considering all of the literature that have reported on the length of implants. So the way this has been expressed is at annual failure rate. So what this shows of annual failure rate of 0.01 basically shows that at the end of the first year there's 1% failure. So by the end of 10 years one would expect that in the maxilla there'll be 10% failure or 90% survival of the implants. Whereas in the mandible at the end of 10 years there'll be only 3% failure and 97% survival. So there seems to be a localization in terms of the survival of the implants, and that's interesting to note, and we'll come back to what may be responsible for that. There have been other systematic reports, and this particular systematic review found that smokers, heavy smokers, are twice as likely to have failure of their short implants as non-smokers. So smoking is another consideration that we have to take into account when we are considering short implants for our patients. Native bone and augmented bone, is there a difference between the two? And the data demonstrate that there's no statistically significant difference between the survival of implants that are placed into native bone or augmented bone. In fact, the failure rate numerically seemed to be slightly higher in the native bone than augmented bone, but there's really no statistically significant differences. Now, let's look at what the different length of short implants were that failed in the systematic reviews that have reported. In this particular study, it was demonstrated that the survival rate of implants, short implants, anywhere from 6 to 8.5 millimeter was relatively high, in the very high 90s. Now, what stands out is that the survival rate of 5 millimeter implant was slightly reduced, below 90% at 89.9%. So what this shows is that we have very good implants that are 6 millimeters or longer, but we still don't have a good 5 millimeter short implants. This may just have to do with where the stresses are that you may need 6 instead of 5 millimeters on the implant. What about surface topography of the implant? In this particular study, the survival of short and machine implants were compared to that of long machine implants, and what was found that in the maxilla, in both anterior and especially in the posterior maxilla, short machine implants had significantly higher failures than long machine implants. So therefore, utilizing machine implants in the maxilla, especially in the posterior maxilla, seems to be associated with increased risk of failures. However, when it comes to rough surface implant, the particular location of the implant did not seem to matter, and implants in all different regions had very good survival rate. Now let's look beyond just the survival implants and look for marginal bone stability of the short implants. Now in this particular study, comparing the marginal bone loss around short and standard length implant, it was demonstrated that during the last evaluation, there was no difference in the marginal bone loss between short and standard length or long implant. Now, this may seem okay. However, when we look closely at this data, we could see that the marginal bone loss reported around both short and standard length implants was relatively high. It was on the average 1.8 millimeters. Now, this may show that there's no difference between the two, but when we really think about it, if you lose close to 2 millimeters from, let's say, a 13 millimeter implant, that's not really that significant. However, when you lose 2 millimeters from a 6 millimeter implant, that's about a third of the length of that implant. So that is a significant linear bone loss. So to me, what this would say is that if we are going to utilize short implants, we should really be cognizant of the potential for bone loss, and we should utilize a strategy to minimize marginal bone loss. Well, one of the contributors to marginal bone loss have been found to be the design of the implant. Certain implant designs are associated with more marginal bone loss. For example, what has been demonstrated that one mechanism for reducing marginal bone loss is the placement of microthreads around the implant. Now, we previously discussed that most of the stresses are focused around the crest of the implant, so by placing the microthreads, it was demonstrated that there is reduced marginal bone loss, about half the amount of marginal bone loss as those in this particular preclinical study of bone loss compared to non-microthreaded implants. So what this may be responsible for this is by placing the microthreads, there'd be less stresses around the crest of the bone, having more stresses around the macrothreads, which are deeper down in the body of the implant. So one possibility is utilizing microthreaded implant. Now let's look at a particular clinical trial that I've been involved with. This is a prospective randomized controlled multicenter clinical trial, and so far there have been 196 implants in 89 subjects. This is a 5-year follow-up, and what is done is that 2 or 3 implants are placed either in the mandible or maxilla, and these are randomly assigned to either short or long implant group. And the long implants groups are 4 by 11. Short implant groups are 4 by 6 implants. These are Astrotech OsseoSpeed implants. And then after 6 weeks, these implants are restored with a fixed splinted provisional restoration. These provisionals are kept in for 6 months, and the final definitive screw-retained prosthesis is delivered at that time. And then we'll follow up the patients annually, once a year, and look at their marginal bone stability. The first year data have already been published. They were published in 2012, and what they demonstrated that when we're looking at the different stages, there's an initial very slight marginal bone loss between the day of placement and loading, and then after loading, after provisional restoration, there actually seems to be slightly gain of bone around the crest of both short and long implants. At the end of this, the marginal bone was almost negligible. The changes in it in both the short and long implant groups. So there was really no difference between the marginal bone changes to either one of those two types of implants. So this is really quite exciting to have short implants with very stable marginal bone. What is also interesting that maxilla and mandible had same outcomes, no difference between the two. So with this particular configuration or design of implants, short implants seem to work well and with stable bone and same outcomes in both maxilla and mandible. Here's one of the clinical cases from this study. You can see short implants on the day of surgery, and then 6 weeks later, provisional restoration fabricated. A year later, you can see the soft tissue response and marginal bone level. And then after 5 years, the marginal bone is very, very stable, and the soft tissue is very stable. And this is a pattern that we've seen in all of the implants in this particular study. So in my clinical practice, if I have a patient like this with 6 millimeters of vertical height, I don't really see a need for sinus augmentation. I think it's just as efficient to place a 6 millimeter implant and have the patient restored. And this particular patient has a dentulous posterior mandible, and as we see when we have natural teeth directly adjacent to an edentulous space, there's usually a ramping of the bone where the bone is more intact around the natural teeth, and we end up with more atrophy as we're getting further and further posteriorly. So we have two issues. One is the ramping of the bone. The second is limited vertical height of bone. So we can see the proximity of the inferior alveolar nerve. So one of the solutions for the ramping issue is to utilize an implant such as what you see here with a sloped platform. The slope of the platform of the implant happens to be a profile implant, Astrotech profile, where there is a 1.5 millimeter of slope between the top of the slope and the bottom of the slope, so we can position the slope so that it's distally oriented, and that way it's more congruent with the bone. And then for the distal implant, we can use short implant. And that's exactly what was done. And as you can see, on the slope, the slope of the profile implant matches that of the slope of the bone, so we don't create a discrepancy as is often seen in these situations where implant is placed on the slope. And then on the distal side, the short implants are placed. These are the atlantis abutments that are fabricated, and we can also control the cement margin so that it's also sloped and follows the mucosal margin. And then the final restoration, and this leads to more stable situation in the long run. Another clinical problem is this particular patient who presented with a very, very highly atrophic posterior mandible in such way that the inferior alveolar nerve was sitting right on top of the alveolus in the posterior region. So every time the patient would wear a complete denture, there is compression of the nerve, producing a great deal of pain. So, as you can see, he has a small amount of bone in the anterior region, and maybe just a slight amount of bone in the posterior region of the mandible. So one solution was to place standard length implants in the anterior region and short implants in the posterior region. These are 6 millimeter implants in the posterior region to provide posterior support that is more stable to prevent any compression on the ridge where the inferior alveolar nerve is sitting on, and the patient is much more comfortable with this particular design of restoration. Now, the application of short implants for removable overdenture has been demonstrated, demonstrating that there's a very high survival of these implants, 96% survival after 1 year. One consideration when we're utilizing short implants can be the potential for increased crown to implant ratio. This is always a concern that's expressed when people are treatment planning, but there's a lot of confusion in this area, and I would like to discuss this consideration. So what do we know about the role of crown to implant ratio on implant outcomes? There is this particular systematic review of the literature on the relationship between crown to implant ratio and implant outcomes, and this particular systematic review found that there's no correlation between crown to implant ratio and implant survival, nor to crestal bone loss. So crown to implant ratio doesn't seem to affect implant related outcome, except this particular study identified higher technical complications in situations where the crown to implant ratio was elevated. So increased technical complications included crown displacement, screw loosening, screw fracture. So these are things that we should think about. Well, when it comes to biomechanical considerations, I think many clinicians equate teeth and implants without any kind of discrimination. Well, this is just to remind ourselves that teeth and implants have different biomechanical properties. While teeth have periodontal ligament that distributes the load along the entire length of the root, what this would mean is that the total surface area of the root will matter a great deal in terms of the support provided to the root of the tooth. So long roots is very important for a natural tooth. On the contrary, with implants, because they're osseointegrated, all of the load seems to be focused around the crestal region, as we discussed. So when we're looking at a situation where there is overloading of teeth, there's widening of the PDL space, but around implants, there's marginal bone loss. So let's take a closer look at this. Now, when we have a situation where the alveolar bone is intact, there hasn't been any marginal bone loss, and the alveolar bone has not resorbed, when we place implants, whether they're short implants or long implants into this situation, the crown that are used to restore these implants are relatively short. They're basically of similar height to that of the natural teeth that they're replacing. As a result, the crown to implant ratio is usually very low, either 1 to 1 for short implants, or maybe 1 to 2, or even 1 to 3. So that is a reality when we're restoring alveolar bone that is relatively intact. Now let's take into account situation where there's been alveolar bone loss. Where there's a alveolar bone loss, which is in many situations, what this would mean is that we're going to have elongated restorations. When we have elongated restorations, that would mean that the crown to implant ratio is larger. Now, what can we do about this? What would be the solution to improving this crown to implant ratio? Would it be simply to place a longer implant? Do we really mitigate the problem by placing a long implant in this situation, which will give us a 1-to-1 crown to implant ratio? Well, if you really think about it, it really would not solve our problem, because the stresses that are on the prosthetic component are the same between long and short implants, because if you use the same prosthetic platform, the stresses are the same. And as we discussed earlier, the stresses to the peri-implant bone is also going to be very similar. So by using longer implants, we haven't really solved our underlying problem of concern. We have simply just used longer implants. So let's find out a little bit more about this and what the evidence shows. Well, one of the interesting studies has pointed out a concept called crown height space. Crown height space is defined as the length of the restoration starting with the cusp tips all the way to the alveolar bone. So this will include the technical crown as well as the abutment all the way to bone. So in this particular study, the investigators used in vitro fabricated crowns of different lengths, and they tested them on the same length of implant, and they wanted to know if there's any difference in the outcomes when we're just simply increasing the crown height space. And what they found was that prosthetic failure occurred at crown height space of 15 millimeters or longer. So what this shows is that the length of the crown, the clinical crown, the crown height space seems to be incredibly important, and the threshold seems to be 15 millimeters. So my suggestion is that rather than focusing on crown to implant ratio, which is a ratio of something where the crown length is very important, but the implant length is not so important, so the whole ratio becomes irrelevant. So rather than considering the ratio, let's consider just crown height space and try to limit our crown length to 15 millimeters. But then if we are going to have to restore implants with crowns that are going to be 15 millimeters or longer, we have to find some other solution. For example, we could consider splinting those implants, those restorations. Let's see if splinting will be an effective strategy. In this particular study, coming from Ohio State, it was demonstrated that by the stress distribution, splinted implants, splinted restorations on implants seem to have better stress distribution, whereas non-splinted implants seem to have more localized peak stresses. So splinting seems to be a good strategy for stress distribution, at least in this biomechanical study. Now, unfortunately, the clinical studies have not borne this out, and the clinical studies have really not demonstrated any difference in the outcomes between splinted and non-splinted restorations. So we don't really have that aspect of the literature as a guide for us. Now, in this study, the authors considered restoration of molar implants, and they compared the stresses in regular diameter 3.75 millimeter diameter implants used with restoring a molar. Compare that to a wide diameter implants of 5 millimeter in diameter, to that of placing two regular diameter 3.75 millimeter implants used for restoration of a single molar. What they observed is that there's a certain amount of stresses when using a regular diameter single implant, and those stresses are reduced by using a wide diameter implant as was predicted in the previous studies. Interestingly, the lowest amount of stress was in situations where there were two implants used that were restored with a splinted restoration. So this may actually be a viable strategy when dealing with situations where we need to reduce the stresses by using more implants and splinting them together. This has already been published by showing that two implants can be used for restoration of single molars. Here's one of my cases when the prosthodontist restored the two implants with a molar, basically the splinted situation, or in this particular situation, two implants were restored with two premolars that were non-splinted. So placing more implants can be one strategy because it reduces the mesiodistal occlusal table. We should also, when we are concerned about stresses, we can also try to reduce the buccolingual occlusal table as well. Now, when we're considering the utility of short implants as a way of avoiding performing bone augmentation, we can also consider an analogous situation where we have horizontal deficiency, and one option is to do bone augmentation, another option is to use narrow diameter implants. Narrow diameter implants are also very useful in these situations because it avoids performing a bone augmentation prior to the implant placement. And you can see also we have restricted interdental spaces, so it helped in this way as well. But in general, by using narrow diameter implants, we could avoid performing bone augmentation for our patients and simplify our treatment option. And there's plenty of documentation for their success. You can see in this situation, a single unit restoration was made. This really speeds up our treatment, provides a viable option for our patients, and it's a very good treatment alternative to performing augmentation using wider diameter implant. Now, we have to be a little bit cautious when using narrow diameter implants to keep it to areas with low occlusal stresses. For example, lateral incisor, maxillary lateral incisor, or mandibular anterior teeth. We don't really want to push the envelope too much with it. One of the questions that arises is that if short implants are so effective, should we just use them everywhere? Is that all we should just stock in our offices and we use short implants in every situation? But I'd like to point out where short implants would be appropriate and where they would not be so appropriate. And there's no question that by having short implants available and offering that as an option to our patients, there's a variety of clinical situations where we come across where our patients could benefit from this, and we could really minimize the invasiveness of doing augmentation technique for them and expand the option and providing care for a wider range of patients. However, there are certain situations where short implants may not be appropriate. For example, in this situation, the patient had an impacted canine, and when that was removed, it left the patient with a significant vertical defect in the middle of an edentulous ridge. Now, you could see that the ridge takes on an atrophic format, so yes, we can place short implants in this situation. However, what we'll end up with is a situation where the restorative contours will not be so favorable. So I think in this case, it would be prudent to correct the alveolar ridge deformity to provide better restorative contour in the final outcome. So vertical augmentation is performed, in this case utilizing tenting screws, and this is a topic for another day, and we were able to correct the vertical deficiency and provide for a better alveolar ridge topography. And now when we remove those tenting screws and replace them with dental implants, the implants are at an even platform, and we're able to restore the patient with reasonable restoration. Or in this situation, where the patient has severely atrophic posterior mandible, you can see that there is a significant ramping from the natural tooth toward the highly atrophic posterior mandible. And when we're looking at this closely, we could see that the patient only has maybe 2 millimeters of vertical height of bone in this area. Obviously, that's not appropriate even for short implants. And because we have natural teeth in the anterior region, that those natural teeth are still in pretty good shape, we couldn't use the anterior region in the parasymphyseal area for restoration. So this is clearly a good indication for doing bone augmentation. That's indeed what that was done, and you can see the proximity of the mental foramen. Again, utilizing those tenting screws, vertical augmentation using xenograft in conjunction with autogenous bone, getting good primary closure, and at the end of it, we have very nice bone topography, adequate vertical height, and you could see that even after vertical augmentation, we can only place short implants, which is fine, but what we have done is to correct the alveolar ridge contour, bring it closer to that of the natural teeth, and the final restoration would be better. The implants would be at a nice platform, and you can see in the final restoration, we have the implant platforms pretty even, and the soft tissues are relatively even. So what about immediate loading situation? Well, let's think about in immediate loaded situation. That's a situation where the implant has not integrated yet. So when we consider that in terms of load distribution, this is what we're going to see. We can see that the stresses that are on the crestal bone length is still not significantly important when we compare implants of different length. By using longer implants at the crestal, we only had 2.8% difference in stresses or displacement of the implants in the crestal, but you can see in the apical areas there is significant more displacement. So when there's stresses to implants, it seems to displace more the apical portion of the implant, and using longer implants can lead to better stability around the apical portion of the implant. But what seems to be more effective is bicortical stabilization, basically trying to engage the apex of the implant into a cortical bone. So if we're planning on immediate loading, my suggestion is to try to use longer implants and try to achieve bicortical fixation by using an implant that's long enough that on the apical portion it can engage cortical bone. So when we have a situation such as this, when the patient has terminal dentition, and you can see that the patient had had severe bite collapse. Okay, so this is a condition where the patient is going to require implants from both maxilla and mandible. Of course, we can place short implants, but that's not really desirable for immediate loading. So when we're considering what she already has, a better situation is to utilize the parasymphyseal area, and to increase the AP spread is to tilt the posterior implants further. So we can use longer implants, try to achieve better bicortical stabilization, and trying to increase the AP spread by tilting the distal most implant. So this is a strategy that will help with immediate loading. However, traditionally the implants that are used for immediate loading are cylindrical implants. And having a cylindrical implant in a tilted situation can be a significant problem because it can lead to a mismatch between the bone and the implant. So what I like to do is to show you a novel approach, which basically the first step is to level the alveolar bone, placing the implants in a tilted position in the posterior region, and when we tilt the implant, the profile implant that I showed you earlier with a slope platform is ideal for this situation, because when you place this implant in a tilted format, it ends up being flush with the surrounding bone, so there's really no discrepancy between the implant platform and the alveolar bone. And we can correct the angulation with angled abutments and pick up the restoration for immediate loading. And this is what we have, immediate loaded prosthesis. So for immediate loaded prosthesis, you really need length, and when we really can't place implants in the posterior region, it's better to utilize this tilted format. And the same thing can be done for the maxilla in order to avoid impingement into the sinuses. So just taking you through the case, tilting the implants in the distal region, picking that up in the prosthesis for immediate loading, and that's what we have for immediate loaded prosthesis. So just to show you an overview, the mandibular situation has tilted implants to avoid the mental foramina. Maxillary posterior implants are tilted to avoid the maxillary sinus, and this is very appropriate for immediate loading. And this is the provisional restoration that was made for evaluating the occlusion and aesthetics. And then this was followed up with a definitive restoration. You can see still the provisional restoration in acrylic. Here's the patient before. After the provisional restoration, she's very, very happy. And then this is the definitive restoration, which is a monolithic zirconia restoration for full arch restoration. Here's the patient before and after definitive restoration. So we have a improved situation for her. So basically, as this case illustrates, when we do have limited bone volume, maybe tilting the implant will be a better strategy to utilize the existing bone in order to avoid the augmentation procedures, and that way we have the opportunity for immediate loading and also for improved anterior-posterior spread. So let's summarize the options that we have for restorations in the mandible. Let's say the first scenario is if we have vertical height that's more than 10 millimeters. Well, in this situation, I would recommend using implants that are longer than 10 millimeters. Even though the short implants have equal outcome, the benefit of using longer implants when we do have available bone is that if those implants for any reason develop peri-implantitis, we're still going to have sufficient amount of bone that's supported. So still I would recommend standard length implants in those situations, and the added benefit is that if there's immediate loading or immediate placement, longer implants will do better. Now, if we have limited vertical height, something in the range of 6 to 10 millimeters of height, I would recommend using short implants. It's really, unless there's special circumstances, there's really no need for augmentation in order to just for the sake of placing longer implants. So shorter implants are less invasive and are equally effective. Now, if you have a reduced alveolar bone with atrophy, but we have irregularities of the alveolar crest, and by these irregularities, we can't just take the bone down and do alveoloplasty, then we'll end up with too little bone. Then in this situation, it's better to perform bone augmentation for the sole purpose of providing for an even alveolar ridge to allow for uniform positioning of the platform of the implant. So augmentation will be necessary here. Now, if we have too much resorption in the posterior mandible, we can just avoid that region altogether and just simply tilt the implant posteriorly, and we saw that the profile implant is a nice situation there because it allows us to do immediate loading. How about the maxilla? For the posterior maxilla, if we have reduced vertical height and there are multiple implants and their height is too little, let's say less than 5 millimeters, we have to do some form of augmentation. I would just say lateral window, sinus augmentation, and placement of longer implants will be appropriate. Now, if we have 4 to 5 millimeters of vertical height, we still don't have adequate height. If it's just a localized area, crestal sinus lift will be appropriate. We don't really have to place a real long implant. We could just basically place implants that are 8 to 10 millimeters in height. And then if we have 6 to 8 millimeters of vertical height, I think short implants can be considered if we have a normal occlusion. But if you have heavy occlusion, if the patient is a heavy bruxer, I would still try to use longer implants because there is a possibility that this patient may lose some crestal bone, and having a longer implant will be beneficial in this situation. So let's just conclude our discussion that length does not seem to be important as long as we're talking about length that is of implant that is 6 millimeters or greater. It's not important for clinical performance of osseointegrated implant. Length is important for immediate placement and immediate loading. Wide implants offer better stress reduction. Increasing the number of implants and splitting them together when increasing the diameter is not possible is a good strategy. Vertical augmentation may still be necessary to restore rich contour, whether it's for the purpose of providing for better contour of the restoration or for aesthetics in the anterior region. Vertical augmentation may be necessary in those situations. And surface topography of implants is a risk in the maxilla, so using rough surface implant, we have to pay attention to the type of surface that an implant has, especially when we're doing implants in the maxilla. And grafted bone is not a risk factor for using short implants. We can go ahead and place short implants in augmented bone. So the whole point of this is that in this process, we shouldn't be like this man who has a hammer and to him everything looks like a nail. It's really about a decision tree. We have to perform our risk assessment, decide what are the parameters, and select an appropriate treatment that suits our patient with their unique clinical situation. With that, I'd like to thank you for your attention, and I hope you found this presentation useful for you. If you have any questions, I'll be happy to address them with you. I have my email for you, and have a wonderful day.